Thank you very much. Good morning, everybody, and thank you very much, Professor Siebenrock, for organizing this. It's a pleasure to be here and to engage in a couple days of great discussion and exchange of ideas. So I'm going to speak today about what we call normal radiographic impingement, and really this is an ultrasonographic assessment of capsular motion and how the capsule is involved in creating problems around the hip joint. So by way of review, we're all familiar with the concept of femoral acetabular impingement. It's an accepted pathomechanical concept about the hip. The classically described cam and pincer variations can cause labral damage and articular cartilage injury and restrict end range of motion mechanics of the hip. We have learned over the years that impingement is a very, very complicated mechanical entity. It's affected by femoral version, by acetabular version, by the neck shaft angle, and by the location of the cam on the head of the femur. We have recently become to be more appreciative of the effect that femoral version has on the mechanics of the hip. There's some beautiful studies that were done here in Bern looking at version and the effect on impingement and how the variations in the version of the femur can affect where the cam affects the acetabulum. And really, version is the primary determinant of hip range of motion. We've been, for a very long time, interested in the morphology of the upper femur, and for those of you who do this regularly, you appreciate that the upper femoral morphology varies substantially from patient to patient and how this affects hip mechanics. This is a study that was recently done by Rob Westerman, who I think is here with us today at the University of Iowa, looking at the morphology and its relationship to version, and there's an inverse relationship between femoral version and the head trochanteric offset, which is a helpful determinant in range of motion of the hip. So we have for a couple decades now been interested in hip ultrasound. Hip ultrasound has become a useful tool in our assessment of hips. The static examination is useful for looking at morphology of the skeleton, and we can look very carefully at the periarticular structures, the tendons, nerves, inguinal floor. But we use it dynamically all the time to look for anterior instability and increasingly to look at what's impinging specifically in the hip. We can see the hip capsule very clearly. We can position the ultrasound probe in order to allow us to examine the hip while reviewing the capsular motion. This is, for those of you who aren't familiar with ultrasounds, you can see the capsule very, very clearly. That's here. This is the labrum, the rim of the acetabulum, head of the femur. This may help you in some videos in the next slide. Let's see if it's going to advance. One more time. I'll point it at my head like Klaus does. Is it moving?
Very slow.
Okay. Well, we can do a dynamic assessment. This doesn't seem to want to play too well, but here's one that's working better. So this is a normal capsular motion. The diagram to the right shows sort of simplistically that the capsule will move out of the way, and you can see here as the hip is flexed, the capsule will deflect away from the joint. So capsular impingement is the opposite. The capsule bunches up in front of the hip and pushes on the outer surface of the labrum, and you can see here the capsule is getting bound between the upper femur and the acetabulum and pushing on the labrum. So we after making many of these observations, we have asked the following questions. Is capsular interposition impingement pathomechanical? And what are the clinical scenarios that are associated with capsular impingement? So this is a case series of patients that we gathered over an 18-month period of time. These were patients from my practice that we referred for ultrasound to dynamically evaluate the hip. when there was hip pain associated with restricted range of motion, when there was not an obvious radiographic explanation for the clinical observation. So these patients represented a variety of different diagnoses. There were 11 patients, 7 female, 4 males, and the average age was 24. So all patients undergo a routine static and dynamic examination done by 2 examiners. The ultrasonographer is my longtime colleague, Marnix von Holzbeek, and I was the examiner. And then we would interpret the ultrasound and correlate it with radiographic findings. So in total, 4 patients had prominent trochanters responsible for capsular impingement. 3 patients had relative retroversion, but not absolute retroversion. 2 patients had prominence or morphologic variations of the anterior-inferior iliac spine, and 2 patients had prior capsulotomy, one with a PAO and one with arthroscopy, and I'll show you some examples. So we divide capsular impingement into 2 forms: primary, when it is related to a skeletal deformity, and secondary, when the patients had prior surgery, such as involving an arthrotomy. Here's an example. This patient presented with restricted and painful left hip range of motion. And if you look at the AP pelvis radiograph, I think most people in this room would say that it looks relatively normal. There are no outstanding problems. The version was 12 degrees. The CT scan, except for some ossification of the rim, looked relatively normal. And then when we examine this patient with an ultrasound, you can see very clearly here that the capsule is getting compressed against the outer surface of the labrum. And the reason this is happening was the trochanter was very prominent. You can see the trochanter here. So this is what we find clinically at the time of surgery. You can see she has very restricted range of motion. And then at the time of surgical dislocation, before the trochanteric osteotomy, there's no internal rotation. And then following the trochanteric osteotomy, you can see closely, this is slowed down so you can appreciate the capsule bunching between the rim of the acetabulum and the base of the trochanter. And so it's this capsular secondary impingement that is deforming the labrum, causing the ossification on the rim and creating the patient's problems. And this is due to a prominent trochanter. Here's another example. This patient was referred to us after having a failed right hip arthroscopy. She then had a right periacetabular osteotomy. You can see that X-ray on the right, but had very restricted range of motion afterwards, and she was quite painful. And so we examined her dynamically. You can see the capsule, which was very fibrotic, being compressed against the rim of the acetabulum. So at the time of arthroscopy, the picture on the left, this is the arthroprobe pulling on the capsule. It's fibrosed to the neck of the femur. This is after starting to release it and doing a little bit of a neckplasty. And then after the capsule is totally freed up. And this completely resolved the patient's problems. So clearly there are limitations to this case series. These are non-randomly selected patients representing a variety of diagnoses. And there's limited but some normative data. It's clearly not a definitive study of capsular mechanics, and in many cases the pain might be induced by the compression of the capsule itself, which is a highly innervated structure. However, we have done extensive range of motion studies on the hip, and we know from these range of motion studies what normal mechanics of the capsule is, which is what we showed earlier in the presentation. And we feel that capsular compression can be pathomechanical due to variable AIS morphology, significant variability in the version and upper femoral trochanteric anatomy, and due to intra-articular and extra-articular adhesions. Based on ultrasound and intraoperative observations, capsular impingement can be a component of chondrolabral injury and hip pain. Capsular impingement is associated with intra-articular labral and chondral pathology in selected patients. And we feel strongly that the role of secondary soft tissue compression, especially the ability to decompress soft tissues arthroscopically, should be considered in the comprehensive evaluation and management of hip mechanics. Thank you very much.